you for joining, everyone. So really pleased to be joined by Nura from the Allies Network, and then we've also got Jazz, who is the lead for this piece of work at the Birmingham and Solihull Mental Health NHS Foundation Trust. So I'll pass over to you both. Thank you very much for coming.
Thank you, Eloise, and good afternoon, everyone. Welcome to this session of BLACHIR Health Inequality Review. BLACHIR, Birmingham Lewisham Health Inequality Review, states that there's 39 health inequalities within the NHS ecosystem. And we're going to actually interview colleagues within the NHS ecosystem to understand what sort of changes or issues have been addressed within those situations. And I would like to first call upon Randeep from Birmingham Solihull Mental Health Trust to tell us about the fabulous work the Trust is doing around BLACHIR.
Would you mind, Nura, if I start off trying to explain to people, because I think we have some people that don't know much about BLACHIR, if I can just introduce them to BLACHIR, because I think Justin has done one, but we haven't done it from the ICS point of view, if that's okay. Yeah.
Okay.
So hi everyone, my name is Onyinye, Dr. Okonkwo. I'm a GP and I chair the task force for the Birmingham Lewisham African Health Inequalities Review task force within our ICS. So within Birmingham and Solihull ICS, we have a task force that is looking at those, like Nura said, the 39 opportunities for action that were detailed in the BLACHIR review, and they asked us to look at. So in a nutshell, for those of you who haven't looked at maybe Justin's presentation on BLACHIR and what it's all about, over the pandemic, our Director of Public Health, Dr. Justin Vanni, and the Director of Public Health for Lewisham looked at why there was a lot of health inequalities that existed between the African and Caribbean communities, and they couldn't understand what was going on with the George Floyd and then the COVID, and we were all dying in numbers and nobody could really understand. So they decided to do a real deep dive to try and understand those determinants of health that might be contributing to what they were seeing. And they had a lot of literature review, they interviewed some patients, they had some academics looking at the research, and eventually they published this research last year that said, look, there are some opportunities for us to be able to improve the health of African and Caribbean patients. And they then tasked us as a system of an ICS. So an ICS is a merger between the NHS, the City Council, voluntary organizations, community organizations coming to work together to try and improve the health of the community. So the Birmingham City Council tasked us as an ICS to see what are we going to do, how are we going to respond to those recommendations or the opportunities for action that they had detailed in the review. So as the Birmingham and Solihull ICS, we then took it away and we formed a task force of which people like Nura, we have 3 community engagement partners, Nura, looking after the African communities. We have Annika Kobler looking after the Caribbean communities. And then we have Michael and Simeon looking after the children and young people, as well as representation from all around the system. So all the big providers within the system are around the table, and primary care, community care, all of us working together to see how we can, each of us, look at the what the opportunities are, what we're already doing, and what we're going to plan to do next. And as part of that, I'm sure some of you might have seen, we're doing some community engagement events, and we're trying to bring the health out from our system into the community. So today, like Nura said, which I'm going to quickly stop talking and hand back to Nura. Today is all about understanding some of the work that is going on, because it's good for people to understand what we are doing, why we are doing, and so that when they see us coming out, people can maybe consider joining us or maybe being part of the conversation. So thank you very much, Nura, for giving me that little bit of time to just introduce the project and what we are trying to achieve. Over to you.
Thank you, Dr. Onyinye. That was a great introduction to BLACHIR, Birmingham and Lewisham Health Inequality Review. And before I start the interview, I wanted to just highlight some statistics from the report around mental health and well-being. So according to the national survey in 2014, 29% of Black women had experienced a common mental health disorder. A higher rate than women from other ethnicity backgrounds. Psychosis was consistently higher in Black populations, in particular males. Findings were less conclusive regarding depression and anxiety. And of course, some of the reasons behind those statistics could be the level of pain is not always acknowledged or recognized in a Black woman. There are myths that medical practitioners believe that Black women have a stronger pain threshold, language barriers, which often affect the way the person's accent or understanding of communication when it comes to health professionals. And we're here today to hear about Randeep, who's the lead on University Hospital Birmingham later on, but we're here with Jazz, who is from Birmingham Solihull Mental Health Trust, to tell us about the work that they've been doing to address some of these issues. Jazz, welcome.
Thanks, Nura. So thanks, colleagues, for joining us today. In terms of the BLACHIR project, we've taken the opportunity to use this framework to really support the wider national framework, which is called the Patient Carer Race Equality Framework. Now, that was in response to a national white paper, which was published, I think, about 3 years ago now, highlighting the immense inequalities experienced by racialised communities, of which the Black African and Black Caribbean communities are two that centrally experience disproportionality in relation to access, experience and outcomes. So our approach to ensuring sustainability and accountability across this work, of which we've still got lots and lots of stuff to do, but we are very much on this pathway and on this experience, has started with us in relation to anti-racism. So if there's anti-racism, we have to establish that there is racism initially. So that first step has been something that our senior leadership teams and our more operational teams have been working through as to what does this mean for our organisation and where does this show up. So in terms of where this shows up, we have data. So across our organisation, we have 4, what we would call them, divisions in relation to focus service areas. And we took the step to actually look at our data in relation to our access, experience and outcomes. And the intention behind that was to create a position for that accountability. So actually, if this is what our data is saying, then what does that mean in terms of practice? What does that mean in relation to systems? What does that mean in relation to processes and also policies? And then we get to our people. And what we noticed was actually, when it comes to utilising this information to create change, we needed some kind of tool. So we've started on a experience around developing an anti-racist framework that is focused on operational colleagues and the individual practices that they deploy. So we're currently in the socialisation space of that, which means we've had 10 colleagues of lived experience and have gone through specialist race equality training to develop the initial framework, and now we're socialising that across the organisation to get feedback. All of that feedback will come back to that original 10 group of colleagues to then be refined and then be published as a framework that will be used in supervision, that will be used in development, and that will be used in relation to that accountability. Because ultimately, from that individual contact comes then the system contact. So while we're working at that strategic level in relation to the systems and processes and the leadership, we acknowledge that there is personal and individual accountability at the root of all of behaviours. So that's the kind of broad overview of the anti-racism approach that we've taken. And then within the patient care race equality framework, we've also got, so the first area is leadership and governance, essentially. So do we have the right leadership and governance to be able to make this work sustainable? So I started off as a community development worker back in the day in response to the murder of David Rocky Bennett. Now, although much has changed, in the same breath, nothing has changed. And I say that in relation to the experience of our people, in relation to the late access of our colleagues, of our people, in relation to our communities. And I frame colleagues in that same experience because we are also the communities that we serve. So actually, having gone through that experience, starting very operationally and being part of that community development cohort to a position where I have strategic leadership now, I'm able to carry that lived experience through and be able to provide that robust challenge in relation to the leadership and governance. The narrative I carry is very much actually we shouldn't need equality diversity leads. We shouldn't need this should be part of everybody's day job, and we should be awake and looking at our actions in relation to that disproportionality of experience, as well as our community ownership in relation to our late access, our community assets that we've got in terms of development and growth and supporting communities to really enable the best version of ourselves and realise those community assets. And we also have a role to play as a mental health organisation to work not as a telling you and doing to you, but actually that hand in glove. So there's true co-production, not just engagement, not just consultation, but true co-production. So that all sits within the leadership and governance space. And then within the second space of the competencies and areas of development, we're working with a EBE-led organisation called Breeze Lab to work with service users across our 3 pilot area services, which are secure care, talking therapies and perinatal, to really use a scenario-based approach to highlighting where inequalities occur. So that scenario-based approach supports service users that are actually within our services to have a vehicle that they can then identify with and also promptly and accurately showcase where inequalities occur, but also from their lived experience, what would help in reducing that inequality. So things like variation around food access has come up, and that's just a really practical example. Something really practically again is the element of confidentiality within interpretation and translation services, especially where communities have very close-knit connections. So actually, how do we still enable that confidentiality and service users to feel safe whilst also getting the appropriate level of service provision in? So we're working with our current provider to ensure that that pathway is clearly mapped out, not for just one service user, but actually from a lens of sustainability. What that then also highlights is the competency of the clinicians that are in front of service users, and we're using a new approach to care planning, which is Dialogue Plus. It has been used in various different areas for some time. We're trialling that in our community mental health team areas to enable a different approach to care planning, which creates a space legitimately around identity, culture, what all of that means. And we've supported colleagues with training materials around cultural humility versus cultural competence. And I think all of these advances, when I speak about them, I speak about them with the caveat of, are they really advances? Are we really driving it fast enough and at the pace that we need? And that's just me being really, really open and transparent around there is a lot more we need to do, but we are very confident that we want to work with communities, with our service users, with our colleagues collectively to ensure that this is sustainable and that we're not here in another 40 years having the same conversation. So that's the competency element. And then the third element of the space is around outcomes and outcome measures. So that element of the framework allows for transparency of data. Now, historically, that has not been available at organisational level, but the national framework puts a responsibility on organisations like ours within the mental health space to transparently share data and also actions relating to improving the access, experience and outcomes that might be shown within that data transfer. So that's just to give you a really, I don't know, you can appreciate there's lots of nuances, and lots of intricacies within that. And I am sitting in I would say, a really privileged position with the ability to be able to lead the equality, diversity and inclusion space. An active prompt that we've enabled within our organisation to showcasing that we really mean change when we are talking about driving this work is the fact that within my portfolio, I initially had equality, diversity and inclusion in relation to workforce inequalities and health inequalities. So what we were showcasing there was that there is parity between the two. The action over here results in reaction over here and vice versa. And actually, to strengthen that approach, what we've done is incorporated the organisational development functionality, which is then the vehicle for driving that cultural change that we really want to see in relation to us becoming truly anti-racist and truly anti-discriminatory. So that's a really broad brush of where we are currently.
Thank you, Jazz, for that broad introduction. Some questions that we may have, and there are lots of questions to be spoken about, but what progress what are you aiming to achieve through your action plans and by when? So we kind of have a bit of more specifics around the action plans that you've developed within your institution.
So right now, within specifically work pertaining to the African and Caribbean communities, we are working with a community partner called Catalyst for Change, and we understand that they are one organisation amongst many that are available. There are opportunities for different organisations to be involved through the Community Collaborative, which is the collaborative approach to improving experience around mental health services. So that's a new way of commissioning and also providing services from a place lens. And the voluntary sector have a collective board which feature as part of that functionality. Specifically across Birmingham and Solihull Mental Health Trust, we've been working with Catalyst to identify and advocate the use of advocacy within our services with a clear focus on secure care provision. And we've taken that focused approach primarily because we started off with the 3 areas in relation to improving experience. And that's one strand that we've focused on. In terms of showing improvements, we have to roll out the framework across the wider organisation and identify localised actions across all services. And I think that's where potentially we have gone wrong historically, as to we take that broad overview and then that service-led accountability is sometimes missing. So we're using that approach to really showcase actually Secure Care have taken this as a focused area to work on. So informal advocacy, peer-to-peer conversations, but also group advocacy is something that they're focusing on. And as another comparison within the perinatal space, there's a focus on Black women and their experience, particularly around perinatal mental health services. So the development and support surrounding, again, peer-to-peer support and working with community assets to ensure appropriate provision in relation to cultural competency, so that taking that cultural humility approach, but also sustaining that through inpatient settings. What does that mean and how do we need to operate differently? That work is to be evaluated towards the end of this year to see actually from a sustainability perspective, what does that mean? But also from a data perspective, does this change the trend in relation to experience, in relation to access, and also in relation to outcomes? So that is something that we're working on currently. And then within talking therapies, it's particularly focused on that translation interpretation service to ensure that people whose first language isn't English aren't waiting longer to access services because of any delays within the translation interpretation provision. And also that is enabled in a confidential and safe way to ensure that community, there isn't that kind of conversation that occurs locally, and there isn't the disclosure within communities that could potentially happen if there is a lot of connectivity locally. So that's the three areas that I could highlight.
Excellent. And that segues into, we've spoken about in the past is employment opportunities where communities can get involved, but also training opportunities for communities that want to go into things like talking therapies. Is that part of your plan as well in the future? Could you let us know a bit about that?
Yeah, so I'm just thinking about the best way to describe it. So if I start strategically in relation to the NHS in particular, there is I'll call it a tool, which is called the model employer. And that model employer conversation creates a space to talk about representation of our local communities, specifically across senior leadership teams. Now, taking a look at that model employer target, initially it was suggested as a target to ensure that all communities are represented in relation to senior leadership across all organisations. And at Birmingham and Solihull Mental Health Trust, we've taken an assertive approach when we initially highlighted our intention. So we actively want to be representative of the communities we serve within our senior leadership team to initiate that representative conversation and also inclusion approach across all of our elements of our organisation. So we were quite clear that our intention is to be representative at senior level. And currently, I believe that we had initially set a target, which is to be reviewed to meet 40% visible representation at senior levels. And that was due to be revised in 2025. And our current position, I believe, was sat at 37% visible representation at senior levels in relation to race equality in particular. That was one drive in relation to ensuring our leadership is representative of our beautiful city and all that it brings. And more operationally, what we've done is ensure that different professions have diversified opportunities for access in relation to, say, for instance, if we're talking about the psychological profession, we were supported by Health Education England with a pot of funds to identify diversifying the access around psychological professions. And our trust lead, Sunny Calci-Lilico, was very successful in trialling out, I think it was 5 colleagues in relation to not coming from the traditional pathways across NHS jobs. There was an intersect of race around care and responsibilities, around the element of social demographic IMD considerations as well. It is currently being evaluated. Sorry, I was looking for more words then. You know, when you've been talking for a while and then you're looking for your words because you just don't want to get it wrong. I was conscious of being recorded as well. And from an experience perspective, getting people in is one thing, but then really enabling them to flourish is where we really want to focus our attentions. And ironically, we've started well, it's not really ironic, it's just the name. So we've started a transformation project approach, not project, which is entitled Flourish. And that specifically looks at what do people within our organisation need to support them to be the best version of themselves. So is that development, is that lateral development or vertical or whatever it might be? Is it around knowing where to go? Is it around interview support? Is it around health and well-being? And all of those considerations are then intersected with a positive action consideration based from our data around disability and racialized community experiences, so that we can offer the right spaces, the most supportive spaces, but also the most supportive tools to enable people to grow within our organisation, acknowledging that we still have disproportionality across our workforce race equality standard data and our workforce disability standard data. So as an NHS, we are, and I say quite privileged because a lot of organisations aren't using their data effectively. As an NHS organisation, we have the Workforce Race Equality Standard, which asks for, on an annual basis, disproportionality around disciplinary grievance experiences, around recruitment experiences, around bullying and harassment experiences. So all of those are published on an annual basis, and we're actively encouraged to take accountability of that information and data.
And I've got the last two questions. I'll put them into one.
Sure.
And these are sort of questions that communities that are probably listening to this webinar would like some information about. So what treatment options will be available to the African community? You can answer it the way you like. And if the African community do want to report abuse or abuse of power, where would they go? What institution sits within your ecosystem to be able to report to?
Okay, so the first question around diversifying treatment options within mental health provision, it is something as an organisation that we're very much looking into. So one example is through the culturally adapted family interventions research project that we're doing, which specifically looks at Black African and Black Caribbean communities and service users in relation to schizophrenia, and actually how can supported family interventions add value and support in relation to improving experience. And in addition to that, there is also the Tree of Life tool that is available through our psychological professions. I'm citing those two because they are the most kind of recent that have been developed and are underway. There are a whole cohort of treatments available within mental health provision. You'll notice the way I'm talking, I'm not a clinician, so I'm not going to go through each individual one or cite them in that level of detail. If that is something that we'd want to explore, we'd have to bring on the medical professions, the psychological professions, to appropriately kind of address that the question and the conversation. What I would like to add on top of that, though, is that within the space of truly becoming anti-racist, anti-discriminatory, we're looking at actually how do we need to diversify further the options and the availability of certain pathways, and if there is disproportionality as to whether that be around access or experience. So art psychotherapy being one, say for instance, we know that that traditionally that isn't a service that is accessed by a majority of racialized communities, whether that be through a referral mechanism or whether that be through the clinician referral mechanism. Now, having looked at that data, we're now identifying where does that role and responsibility sit? Is it because communities aren't informed or don't know, or is it because there's a clinician requirement to actually look at how they refer into that mechanism? So we're being consciously curious about the data to improve the access, experience and outcomes, again, across all pathways. what my plea would be is that if people have ideas, if people have preferences, and if people have insight, then please do share that with us, because we honestly do want to take that and work with you in relation to creating that sustainable change, whatever that might look like. And that isn't about simply taking that and running away with it. It is very much about working collectively, like I said initially, hand in glove, to improve those experiences. And your last part of the question, sorry.
Yes, so if a community member has an issue to report, where would they report an issue of abuse or anything like that?
Yeah, so it's a subject matter that we're consciously working on with the support of Catalyst for Change, and also advocates we've got through Catalyst for Change, and our complaints and patient liaison services have highlighted that as a significant action to improve connectivity with local communities, but also highlight the pathways. So on our website, in terms of the Birmingham Solihull Mental Health website, you can simply put into any search engine, raising complaints or concerns to Birmingham and Solihull Mental Health Trust, and the pathway is quite clearly outlined there, and also that information is also available through translation and interpretation services if different either audio formats are required, or different written languages are required on paper format. So we can make those available when and if service users, colleagues, communities wish.
Thank you so much, Jazz. You've done great work within that institution, and you carry on doing the great work. And we'll have another webinar probably sometime in next few months to update everyone. But that segues into our next guest, Randeep from University Hospital Birmingham. Welcome.
Thank you, Nura, and apologies to everyone for the Black History Month event at Park Hotel. Can you hear me?
You have a connection issue, Randy.
Oh, do I? Can you hear me? I can hear you.
We can hear you, yes. It's just a bit blurry, yes.
Very good.
Randeep, do you want to turn off your camera? Just turn off your camera completely.
Sure. Better for me. Can you hear me now?
Yes.
Nura.
Yes, so Randeep, before you start, obviously we are going to do some introductions and then carry on with the interview. So I'll introduce you to Randeep, who's going to talk to us about the great work that University Hospital Birmingham is doing. Welcome, Randeep.
Thank you, Nura. Can you hear me now?
Yes.
Okay. Is the connection?
There's still a bit of an issue with the connection, I'm afraid.
Okay. Shall I carry on and we work our way through it, and hopefully it'll get better?
Please. Yes.
Yeah. Okay. Thank you for inviting me, Nura and Dr. O. And you've just heard Jazz speaking, and Jazz is somebody that's teaching the rest of the system off with many of the things that we're doing on equality. So if we've got platinum standard with Jazz, I would probably say that many of us can learn from the mental health, and we are a work in progress, definitely. Now, what we're doing with reference to BLACHIR specifically, are you happy to proceed on that basis?
Yes, so if you just tell us a little bit more about what your institution is doing around BLACHIR.
So by Dr. O and the BLACHIR task force to look through the recommendations, all 39 recommendations of the BLACHIR report, and essentially think about what we as a private provider at University Hospitals Birmingham need doing in response to those recommendations. Earlier this year, and I think actually at the back end of last year, December, presented back what we think would be our top priorities, but what we do was go through each of the 39 recommendations, and there were some that were not necessarily directly for provider organisations, they were for the ICB, for example, and we thought that was still for us to focus on some of those as UHB as well. So having gone through each of those, we presented to BLACHIR and said what we wanted to focus on as an organisation and where we thought we could add more value. And those there were some recommendations totally relevant to us as a large acute NHS trust provider. So we've looked through those, and then more recently, Dr. O asked us to think about what top priorities were. I think we were asked to think about priorities, and what we've done is we've included the top, because there's a lot of work that we're doing around maternity services as well, and we wanted to include those. Nura, would you like to go through each of those priorities briefly, just to sort of give you headline information?
Yes, just briefly, yes, and then we'll go on to questions.
Okay, so do not attend items. That was priority number one. So we have within outpatients in particular a number of communities that when our data, so the starting point was looking at some of the data that already exists in the system and within our own organisation, would identified that actually there were individuals not attending their outpatient appointments. So one of the focuses is to reduce health inequalities and also the do not attend rates, Black and Asian patients specifically. And we've said that we would try and reduce that by a percentage of 10% by April of next year. Now that means that there needs to be a concerted effort in working closely with our communities to better understand, why people are not attending. So BLACHIR brings us and gives us a brilliant platform by which we can do that, because it is about working in partnership with the communities, and any solutions that are being produced need to be co-produced with those communities. So that's one of our priorities. The second, sickle cell thalassemia are not, we're not the of excellence in the region for that. That's City Sandwell. And one of the things that we've adopted is there was a all parliamentary report called No One's Listening, and that was an inquiry into why patients with sickle cell specifically are facing the problems that they face when they go into NHS trusts. And so what we said is our aim is to improve the experience of sickle cell patients at UHB. So although they may not necessarily, those patients with the condition of sickle cell may not necessarily come to our trust or our front doors in particular, so the A&Es for treatment, they may be carriers of the sickle cell trait, in which case they would need to have some sort of flag that's identified, so that the pain that those patients go through, and again, a bit like Jazz, I'm not a clinician, so we'd need to bring a clinician in to talk specifically about those conditions and the management of pain specifically, but that those pain are taken seriously. And there is a steering group that we've set up, and it does have people who are experts in sickle cell supporting us. We've got nursing staff as well as doctors that sit on our steering group, and we are looking at how we can take the recommendations again from No One's Listening and incorporate those in how we support patients coming in, where their primary reason for coming in might not necessarily be sickle cell, but it's about how we support those patients across their entire clinical journey. So that's priority number two. Priority number three is something that we're doing more widely across the ICB anyway, and that is about cultural safety and humility. What we've identified, and our chief nurse is leading this piece of work, is that we need to have a better understanding of patient cultural and religious needs. And specifically, we need to be able to ensure that our clinical staff have that understanding. So one of the groups that's been set up specifically looking at cultural safety and humility started and has had a couple of meetings where we are looking at ways in which we can ensure that all of our frontline staff, so those delivering care, understand the populations they're serving and the cultural requirements of those communities, including the religious requirements as well. So that's a great opportunity for us to do more in this space, but to work across the entire ICS, ICB space, because we know that there is some work that's being led, particularly by Birmingham City Council on this area. And then priority number 4 for us, as I mentioned already, is about the maternity neonatal improvement programme. That's something that we're delivering at UHB anyway, and there are great opportunities here given the recommendations in BLACHIR and also what we know about adverse impact that many patients have that are particularly Black women when they enter into maternity and neonatal services. And so it's about how can we use the improvement programme to really reach into those communities and understand what we should be doing more of, and also sort of, you know, that co-production piece that I've talked about already with reference to maternity and neonatal services. So that's the headlines, Nura.
Thank you so much for that introduction, Randeep. And of course, that segues into maternity. I'd just like to highlight some statistics from the BLACHIR report. In the UK, Black women are 5 times more likely to die in pregnancy or childbirth than white women. The outcomes for infant death and low birth weight in Birmingham are consistently poorer compared to England and Lewisham. In Birmingham, the highest infant mortality rates in the BLACHIR communities were found in mothers born in the Caribbean, which were 1,000 live births, and Central Africa, 8.3 that's live births, and this remained to be so far over time. And so that goes back into some of the reasons for this. You know, we talked about Black women hold, there's a taboo or myth that medical practitioners think Black women are having strong pain thresholds, or there's language barriers and other barriers to access to those services that are available, which some people don't even know exist. So I'd just like to go back into the questions that I'd like to ask, and what are the aims to achieve through your action plans and by when? So what sort of aims do you want to achieve, and what are and by when are those action plans going to be completed? Randeep?
Thank you, Nura. Hopefully you can still hear me. So
Yes.
we, through the maternity neonatal improvement program, there are 900 recommendations from various reports nationally, CQC that sort of came and visited UHB, and some ICB recommendations as well. What we've done is incorporated, given that Bev Baker and myself, Susan Price in the organisation, are part of the work on maternity neonatal services, working with our Director of Midwifery, Carla Jones-Charles. There's a great opportunity for us to incorporate BLACHIR recommendations, and that's what we've done. So there are 7 work streams in total for the maternity neonatal improvement programme. The recommendations locally, as well as have borne into those statistics that you've highlighted. And what that means is those national reports are something we've got to report on, but actually there's an opportunity for us with the knowledge that some of us have working on health and incorporate that at an early stage where we know we've got to make the improvements within our services. So we've sort of embedded the BLACHIR recommendations in the work that we've got to deliver going forward. You've asked about a timeline specifically. That timeline is now. We're working through getting the overall programme plan built and ready for our board, and also in November of this year. But actually later on this week, there will be an early opportunity for colleagues who are key stakeholders in our maternity neonatal services in the system, and also sort of regionally and nationally, to come and a event where we will be talking through those plans. And as they are developing, there will be further opportunities for people to engage within those discussions. Now, it's really important, given that we've talked about co-production, that those conversations continue. And what we are doing is we're working with the MNVP, and they are where we have the voices from patients, how they think our services could be improved. And it's about them being part of that journey right from the outset. So what we've got is the colleagues that represent VP, so the patient partnership voices, they are essentially coming from each of those work streams. They will be there at the engagement. So this is how it's done. And what's really important is on how we can improve. And the key thing here is the improvement trajectory. So it's not just about listening, it's really hearing what we're being told, and then taking that on board and making sure benefits of those suggestions and improvements sought. And then, you know, we're coming from an informed position where individuals have told better. Does that cover your?
Yeah. Yes.
I can go on and tell you a little more about.
I think I'll go into the next question because of time. And in terms of employment opportunities or changing the culture of that institution to meet the needs of communities, if you could just highlight a couple of things the institution has done around that.
Okay, if I may, I'm just going to go back very quickly to something else that you said on the last one, and I will come back to the employment opportunities. So in terms of something else that you talked about, it's really important that we avoid stereotypes. And that, you know, what we mean by that is, you know, as you said, about pain thresholds, and that is something that actively commented on those national reports as well. And there is a sort of LNS, and so each of our maternity services across the to hear, look, and there is an equity plan that has been developed by our that work that we know. So there are specialists who have things that you presented. We need to do as providers in our respective organisations is to take that learning and then embed it in practice we are delivering, you know, every day by way of our services. Just to give you a reassurance that there are will have been seeking advice from and will continue to do so. And there is something about the language barriers that you talked about as well, Nura. In the language, it's really important,
yes,
that we the communities we're serving. One of the things we're doing is trying to identify top however many number of languages that are spoken within the services that we deliver, and that work is part of the maternity natal improvement programme as well. So I just wanted to give you those 2 extra bits there. In terms of employment opportunities, as an anchor institution, you will be familiar with the fact that UHB is one of the larger organisations within Birmingham Solihull ICS and in that and the ICS space. So it's very, very important and built into our fairness. It's likely to change as the organisation is changing as well at the moment. But we know that within that there is a commitment from the organisation to really recruit from our local communities. So there are more who are interested in working at HR colleagues. But if anybody wants to pick up with me, I can steer people in the right direction as well. I'm happy to do Nura. But there is an importance of kind of representing the communities we serve. But going beyond that, there is an importance of ensuring that representation takes place at all levels of our organisation and the entry stages of the organisation. So there is much more that needs to be done at UHB, and it is being taken very seriously. That are on board. That is up to exec, chairing a meeting. That's extremely helpful in terms of having our voices heard. But in addition to that, our networks, our staff networks are really active. And actually the event today that I'm at is being led by our BME network. So it's Olga Leach-Walters and Bev Baker that are running that particular event, as well as our inclusion.
Thank you so much, Randeep, and that is all for now. And thank you for everybody for attending this webinar. If you have feedback or any questions, please do email Eloise. And yes, it's a lovely Wednesday, and I wish everybody a good evening, and thank you.